Hello everyone. The topic of today's lecture is Pit Fissure Sealants. A pit is defined as a pinpoint depression located at the junction of grooves present over the grinding surfaces of the teeth, and fissure is defined as a deep cleft between adjoining cusp of a molar or premolar, usually located at the junction of developmental grooves. Pit and fissure sealants are the term given to the sealant, which is used to describe a material that is introduced into the occlusal pits and fissures of caries susceptible teeth, thus forming a micromechanical bonded protective layer, cutting excess of caries producing bacteria from their source of nutrients. Then the question comes, why to use sealants? The fissures and pits are normal anatomical findings in a dentition and caused by faults in dental enamel. Shallow fissures may not be problematic but be self-cleansing and resistant to dental caries. However, deep and narrow fissures tend to lead to tooth decay. Both pit and fissures act as areas of initiation of caries due to food retention. To prevent dental caries, it is a safe, efficient, and effective method of prevention of pits and fissures caries. Dental caries are defined as a progressive, irreversible microbial disease affecting the hard parts of tooth exposed to the oral environment, resulting in demineralization of the inorganic constituents and dissolution of the organic constituents, thereby leading to a cavity formation. It has been well documented that occlusal surfaces in young patients have a higher caries susceptibility. Unfortunately, fluoride is not nearly as effective in the pits and fissures, where approximately 50 to 80% of the decay is found. The reason for this high rate of caries relates specifically to the pit and fissures morphology, and bacteria are able to breed in deep. In many cases, toothbrush bristles cannot reach to the depth of these spaces to remove bacteria. The susceptibility is the upper and lower first molar is higher susceptible, that is 95%. Upper and lower second molars are 75% susceptible for dental caries. Upper second bicuspids are 45%. Uh, of the chances are there to get affected. First bicuspid is 35%, lower second bicuspid have 35% of the chances, upper central and lateral incisors have 30% of the chances to get affected. Upper cuspids and lower first cuspids have 10% of the chances to get affected by dental caries. Lower central and lateral incisors have 3%, and lower cuspids have 3%. Caries susceptibility of individual teeth surfaces progresses through occlusal, then to mesial, to buccal, and to lingual later. Sealant are the most effective clinical technique to prevent pit and fissure sealants, while the rates of sealant retention on occlusal surfaces are relatively high at 5 years. Sealant retention for buccal and lingual pit and fissures of molars is considerably lower. There was 88% completed sealant retention of the self-cured sealant, and the high cure sealant had a retention of 81%. These data indicate that while the loss of sealant from occlusion surfaces averages 5 to 10% a year, for buccal and lingual surfaces, the percentage of the sealant loss increases 30% per year, rendering this procedure less reliable. Thus, based on sealant retention rates, it follows that the occlusion surfaces should be easier to protect from caries than buccal or lingual surfaces. Historical background shows that Pilchen used zinc phosphate, and Klein and Knudsen used ammonium silver nitrate. Extension of prevention was introduced by G.V. Black. Prophylactic odontomy was by Hayat, and many more. Classification includes polymerization methods, resin systems depending on presence of fillers. Next is depending on the color. Glass ionomer is one of the most common form of sealant used, which was invented by Wilson and Kent in 1972 in London. Has a good characteristics to be used as a pit and fissure sealants, as physiochemical bonding with enamel and dentin is good, release of fluoride ions. Then it has karyostatic and antimicrobial activity, biocompatible, resistance to oral fluid, and it's easy to use. Studies of use of glass ionomer cement and resin modified glass ionomers as fissure sealants indicate significantly lower retention rates than resin-based pit and fissure sealants. However, several studies have shown that glass ionomer sealants are most commonly used and based on the remnants of the cement in the fissures, as well as increased levels of fluoride. The use of glass animal sealant has been suggested for erupting teeth where isolation is a problem. Requirement, it should have high flow properties, that is low surface tension, adequate working time, rapid cure, good and prolonged adhesion to the enamel, low absorption, should be similar to tooth structure, minimal irritation to tissues, karyostatic action, and match to the tooth color. Syndication is caries occlusal anatomy. If pits and fissures are separated by a transverse ridge, a sound pit of fissures may be sealed. Carious pit of fissures, deep, narrow pits and fissures should be sealed. General caries activity, mild many occlusal lesions, a few proximal lesions. Recent erupted teeth are also more susceptible. The contraindications are many proximal lesions shouldn't be included. General caries activity where it is high in rate. Sound, broad, well coalesced pits and fissures. Teeth without caries, free for 4 years or longer, shouldn't be included. It is contraindicated where rampant caries and interproximal lesions are seen. Occlusal surfaces are already carious, is also contraindicated. Tooth present in mouth for many years and there is no evidence of decay. Setup for the sealants, these are the required instruments which are to be used for the Pit and Fissure sealants. Step-by-step procedure. First is the cleansing of the tooth. Second is the tooth isolation, enamel etching, then the application of sealant material, then the curing of the sealant material, inspection of the sealant, re-evaluation of the sealant to be done in the end. So cleansing of the tooth requires the use of profile active cup and pumice with water. Run Explorer through the grooves to remove pumice and mechanically prepare the tooth. There should be no need of anesthesia. Thoroughly wash, dry, and then re-examine the tooth surface. Next step is the tooth isolation. To maintain a dry feel, use rubber dams or cotton rolls. If the tooth is contaminated with saliva, the etching must be done over again. Then the enamel etching is to be done by 37% phosphoric acid in gel form applied 2 to 3 way the cuspal, inclined to create micro porosities within the enamel. Etch tooth 20 to 30 seconds. Fully rinse and dry tooth should be created. Is the picture showing how the sealants affect. Then the application of the sealant material. Apply the sealant material according to the manufacturer's direction. A brush is used to allow it to follow the curvature of the tooth, and the sealant may be light activated or self-curing. Avoid air bubbles. Curing of the sealant material, visible light is used to cure, and don't touch tip of the cure light to the sealed material. Inspection of the sealant, use of Explorer to ensure that all the grooves are filled. Verify the sealant doesn't extend over the marginal ridge of the tooth. Check for the occlusal interferences. If necessary, remove excess. No contact points on sealants, and there should be no use of further polishing. Last step is the reevaluation of the sealant. Observe the sealants at all future appointments. One may need to reapply the sealant. Reapplication along with the fluoride and other prevention measures can provide 100% caries-free restorative-free patients. Thank you. With this, we come to the end of today's lecture.